Good morning, good afternoon, good evening. Welcome to the Health Diplomacy in War and International Conflict webinar. We are having people joining in. Just as housekeeping before we start, this webinar is being recorded and it will be shared with participants. And this webinar is conducted in English. Please note that you could use subtitle translation in your preferred language, following the instructions in the chat. We will have a round of discussions with our panelists following by a Q&A. So I would recommend and suggest that please use the Q&A session to pose your questions as well as the chat to introduce yourself, your organizations, and interact with the other participants. If you have any difficulties in terms of technical difficulties, please do not hesitate to engage with one of our teams. So now to start, I want to introduce myself. I'm Catherine Obais. I'm the founder and executive director of the Health Diplomacy Alliance. It's a Geneva-based nonprofit organization that works globally to promote health diplomacy and to advocate for cooperation and the effective global health work and priorities of health within foreign policy implementation. We are delighted to co-host this event with the Global Health Center from the Graduate Institute. We understand that this is really a timely webinar because international conflicts and war are increasingly prevalent, mostly permanent, where we see health diplomacy has become indispensable for addressing urgent health challenges and the rapid deterioration of already weak health system in crisis zones. So today's webinar will focus in distinct health needs emerging from various conflict zones, the limitations and the priorities of health diplomacy and its relationship with humanitarian diplomacy. We aim to explore how health diplomacy contributes to resource mobilization, the strengthening of the health systems in crisis that are affected, and how it facilitates long-term peace-building efforts. Health Diplomacy Alliance is deeply committed to advocating for inclusive cooperative policies to ensure that health access and protection of vulnerable populations is guaranteed. We understand that we are now currently in a critical situation as we see continued conflicts that are they do not have sometimes the tensions and others are intensifying in terms of the escalation. If we look at the expenditures that currently an estimate by 2023 of 2.44 trillion of US dollars, which is sometimes overshadows the much needed investment in the health sector, and especially in crisis recovery. If we look at, for example, the WHO biennial program budget from 2024 and 2025 is only of 6.83 billion. And they just recently launched the investment round to be able to mobilize those resources that are needed, which necessarily go into emergency or response in crisis. At the national level, OECD countries on average spend only 8.8% of the GDP on health, and the rest is between 2 or 5 of the GDP. And as we know, it doesn't go especially into this crisis. We have seen a decrease in terms of ODA and also to programs in health as well. So we understand that there is an urgent need to align these priorities and to focus on these priorities, and health diplomacy is key to mitigate this compounding crisis. We are currently having, I cannot list everything, but I would like to highlight that we're having health system collapse. We have hospitals, clinics, and we have essential services that are damaged and disrupted for the care of millions. We have an increased displacement of population, exposing vulnerable population to additional risk. We have a spread of infectious disease, especially in refugee camps. We have the mental crisis that is a prolonged trauma and mental health disorders in population, in children's and in young and elderly population, and especially on health workers, and as well that there is limited access to mental health service in these areas. We have a compounding accumulation of other crises. We have the triplet planetary crisis that is exacerbated when we are in conflicts: environmental, climate change, biodiversity, the worsening of food security, water scarcity. We have something that it is within the core focus of our alliance. We have noticed that there is a limited and unregulated antibiotic use, which is worse in the antimicrobial resistant crisis, issuing and creating public health risks. So to dive into what we want to see within this webinar, our panelists will bring an invaluable insight on what they're working in the intersection of health diplomacy and humanitarian. And for that, to have a little bit in the history and context, in terms of the health systems training in those conflicts, we going to have Dr. Abdul Karim Sayed, who's a research fellow in the Department of War Studies at King's College. He has an extensive experience, including roles at prominent institutions, NGOs, and he's been leading humanitarian health programs, and he specializes in health systems strengthening humanitarian health at the public health impacts of conflict with a medical background in neurosurgery. So I pass the floor to you, Dr. Sayed.
Thank you very much, Dr. Catherine, for the introduction. Really, thank you for hosting this crucial discussion on health diplomacy in war and international conflict, as we are witnessing more and more conflicts, sadly, and those conflicts are becoming more urbanized, more protracted, which means they have more civilian casualties, and we need to discuss more how health diplomacy can fit in to mitigate these consequences. So my career myself began in clinical medicine, and then as the conflict escalated in Syria, my journey led me to humanitarian health work on the front lines. But from there, I transitioned to public health and eventually into health system and policy research. But throughout this journey, health diplomacy has been a core part of my own journey, evolving from a skill set for negotiating access and safety in high-risk zones to a foundational approach and value for building resilient, self-sustaining health system in complex settings. And sometimes we often talk about health diplomacy in terms of negotiating cross-border or cross-line interventions only. But I believe, and I think this webinar is really broadening this lens. So health diplomacy is not just about negotiating access. It is more to deal with, all issues related to health systems. Dr. Catherine mentioned now a few issues like attacks on healthcare, like the issue of antimicrobial resistance, or all issues that are really at the core of establishing equity, resilience, and local ownership within health systems. And this makes health diplomacy a skill at the core of sustainable healthcare in complex settings. So to truly appreciate the role of health diplomacy, I would like first to unpack what we mean by health systems in conflict settings. So I developed a framework for health systems in complex settings that can differentiate between the different phases of conflict. So because in each phase, health systems can have different, or should have actually different goals, and sometimes the stakeholders involved in the health system differ slightly as we go throughout the conflict. So for example, while in the active conflict, the goals of the health system will be on saving lives, on health access, responsiveness. When we move toward early recovery, we need to think more about social and financial protection, and then later we need to focus more on universal health coverage. So focusing on these different phases of conflict, I will discuss how we use actually health diplomacy in these different phases. So starting from the first phase, which is pre-conflict, we need to focus here on building an equitable health system with a foundation in preparedness. This includes equitable resource allocation, so the system is positioned to withstand shocks. So for example, in Syria, unfortunately, before the conflict, inequitable health resources distribution existed long before the conflict, and certain regions in the country had very limited access to critical health services compared to other regions, a disparity that exacerbated vulnerabilities as the conflict began. So equity then is not just a value, it is a necessity that prepares communities to prevent conflict later. And health diplomacy in this phase is crucial for establishing partnerships that can step in if conflict emerge. So the second phase, when we talk about active conflict, there are many issues that encounter health systems that need a lot of skills related to health diplomacy. So when conflict strikes, health systems usually collapse or will be severely affected. And here there are many issues, such as the first issue that come to mind is attacks on healthcare. Attacks on healthcare facilities, unfortunately, are really prevalent these days. So, for example, the example in Syria, only in 1 year, which is 2016, there were more than 200 documented attacks on health facilities, mainly by the Syrian regime and their allies. But all conflict parties actually were committing these attacks on health facilities. So the problem is that this became a tactic that severely impacts healthcare access and trust, and even the health-seeking behavior will be affected. I've met some patients in Syria that they were telling me, I do not feel safe to stay in a hospital. So please discharge me as soon as my treatment ends, because they do not feel that this place where they receive their medical treatment is safe. And we are seeing this again and again. We've seen this in Afghanistan with the Kunduz attack, and we've seen this now. We are seeing this, unfortunately, now in Gaza. So in some of my papers, mainly with the Chatham House, I discussed how it is important to document and report these attacks, because first we need to understand the scale of the problem, and then we need to protect the health workers. One of the strategies that was implemented in Syria, which is called the HALA system, HALA system, this strategy developed an AI sensor-trained system to predict airstrikes and then to send warnings to health facilities so health workers can evacuate and patients can evacuate. So here, health diplomacy is really important, not just about protecting facilities, but also about reinforcing international legal protections for healthcare workers as neutral entities in conflict. And those are really important. One of the exercises that I was involved in was what we call the deconfliction exercise. So the UN OCHA tried to implement this exercise in Syria. Unfortunately, the mistrust between actors meant that actors do not share the coordinates of their facilities. And also some of these facilities where they did share their coordinates were attacked the next day, which really the trust will become really a contested issue. Another issue in conflict settings is really outbreaks and pandemics. For example, when the COVID-19 struck in conflict in Syria or in Iraq, there was a huge, it was a huge challenge. The health system was not prepared. And the negotiation here is really on how to mobilize local resources, because we were not able to rely on international resources. So it's really the negotiations on the community level and explaining to them the importance of this response and how to really engage with local leaders. That this was really vital in promoting community-driven initiatives like testing and quarantine measures, even in remote areas. This innovative community-centric approach required diplomacy to ensure community trust, collaborations, and active participation. Similarly, during the polio outbreak that I was involved in between 2014 and 2016 in Syria and Iraq, we had to negotiate access with a Nusra Front, with the Islamic State in Iraq and Sham. So these negotiations were very sensitive because we wanted to ensure that we reach each single child. And lastly, the issue of medical evacuation is really important. For example, the evacuations that happened in eastern Aleppo and in Ghouta, those evacuations were possible only through delicate negotiations, as documented in many reports. And I documented this in one of my papers on targeting healthcare in Syria and how the evacuations around port displacement or critical issues were happening. Lastly, and later, if we move to the early recovery phase, we need to think about rebuilding health services and institutional development. In early recovery, the priority shift now towards rebuilding the health infrastructure. And here, health diplomacy is really important to know how to prioritize the interventions and how to engage with the relevant stakeholders, because the last thing you need in early recovery is to fuel the conflict itself. So you need to be really careful on terms how to use health as a bridge of peace, but choosing your stakeholders very carefully. And lastly, in post-conflict development, priorities need to be set for resilient health system And this is really important in terms of working with local actors, working with emerging authorities on how to open channels all the way from the communities to the meso level to the technical entities in terms of how to, in fact, to build resilient health systems. So there are many challenges related to the implementation of these health diplomacy skills in complex settings, but also there are many opportunities where we're able to vaccinate a lot of children during the polio outbreak that I mentioned in 2014. We're able now to embark a very complex research project called Research for Health System Strengthening in Syria that started 3 years ago, and we were able to engage with different actors. So things are possible, but we need to be really mindful on how to use health diplomacy wisely to not only negotiate access, but also think about building resilient health systems in complex settings. I'll stop here maybe, and I will intervene later in questions and answers.
Yeah, thank you very much, Dr. Kesaya. That's really interesting to have insight, including of the consideration of how we negotiation in conflict zones, especially what you mentioned with your experience in Syria and Iraq, and also the post-conflict aspect in the work with local actors, and how health diplomacy not only is there to the access of those vaccine, as you mentioned, or health services, but also how to strengthen the health system as a whole. So we're gonna pass to understand a little bit more in the intersection of health and humanitarian law. And for that, we have with us Dr. Anisa Belal, who is the executive director of the Geneva Peace Building Platform and who had recently successfully closed the Geneva Peace Week 2024, a tremendous event. Dr. Belal is an international lawyer with over 18 years of experience in conflict studies, focusing on armed non-state actors, and has served as a strategic advisor on international humanitarian law at the Geneva Academy. She had held different positions with various organizations, including the International Committee of the Red Cross, the UN, and currently she teaches at Saint-Paul Paris and the University of Bern and holds a PhD in public international law. So I give the floor to Dr. Annalisa Belal.
Thank you very much, Catherine and Dr. Abbas, for, first of all, for the invitation to this excellent and timely event, as you just mentioned. There are some works at home, so I hope that you hear me well. The idea of my presentation is to highlight the big lines of what the law of armed conflict stipulates when it comes to the protection of healthcare, of medical personnel, but also of the wounded and sick, and also to talk a little bit about how the policy world addresses the contemporary challenge with regard to respect and implementation of these norms. So, first of all, one has to remember that, in fact, the protection of the wounded and sick is really at the heart of the law of armed conflict. It's the origin of the law of armed conflict. The very first Geneva Conventions in the 19th century was about the protection of wounded soldiers in the battlefield. And the rationale behind the norm was that it had to be ensured that these wounded soldiers would be collected and cared for by specific medical personnel, and so that would have access to the battlefields through ambulances or mobile units, which would be protected by an emblem, and that these wounded soldiers would be collected irrespective of their nationalities, because the battles at the time were involving soldiers of different nationalities. And so there was already the idea that they should be the impartiality of the access to healthcare, or to be at least collected, to be treated from the battlefield. And of course, this has evolved to expand this protection to the different, let's say, beneficiaries of IHL, and namely not only the wounded soldiers in the battlefield in the ground, but also at sea, and then finally wounded and sick civilians. And so, in parallel to this protection that was afforded by IHL, of course, IHL also needed to protect the ambulances and the medical units and the personnel who would give care to these wounded and sick. And so there is a parallel protection when it comes to indeed wounded and sick under IHL. In a nutshell, there are, if you want, 4 sets of rights and responsibilities that you can find within the law of armed conflict, international humanitarian law. I use the 2 terms in the same way. First of all, of course, the obligation to care, the obligation to collect, the obligation to protect the medical personnel, and of course the obligation to respect not only the medical personnel or the wounded and sick, but also to respect the medical mission and all the ethical standards that are afforded for the medical mission. As I highlighted at the beginning, one could wonder what or how are the notion of wounded at sick, which is a terminology which is a bit special under the law of armed conflict, how are these defined? And it is indeed quite important to define this specifically. So, as I said, these are persons either belonging to the military or to the civilians who are wounded and sick because of trauma, disease, or other physical or mental disorder or disability, and that are in need of medical assistance or care. And so it goes beyond the wounded and sick through the armed conflict. It covers all the persons who are in need of medical care. And it also covers, for example, pregnant women, which is included in this definition of wounded and sick. What we should also remember is that this definition of wounded and sick also covers persons with mental disorder or disability. And this is a category of persons which we tend to forget in armed conflict situation because they need particular specific care in order to be evacuated. For example, if you think about persons who are blind or deaf or cannot walk or are in a wheelchair, and all these require specific precautions to be taken, which are obligations for the parties to an armed conflict. When we go to medical units and personnel, these are defined also quite broadly. It can be a hospital, but it can be also a mobile medical unit. Doesn't need to be in a fixed building. And it goes as well with medical personnel. Doesn't need to be necessarily in a very formal ambulance, but it can be a mobile unit which is protected by the emblem. And what is also interesting to remember here is that medical personnel can belong either to a state armed forces, so official state armed forces, but it can also belong to a non-state actor. And so medical unit and personnel are protected because they are doing a medical mission, but not because of the type of parties to the armed conflict they belong to. Now, what is indeed the scope of protection? So the wounded and sick, defined as broadly as I just did, they are protected, of course, from attack. So they cannot be killed, they cannot be tortured, they cannot be arbitrarily detained, for example, and they are protected not only as civilians, but if they are members of the armed forces, who normally members of the armed forces can be targeted because they are military objects, but because they are not in a position to be involved in using armed forces, since they are wounded or sick, then they are also protected from attack. Of course, the wounded and sick, they can also lose protection. They lose protection as soon as they become a threat to the other party. For example, if they use a weapon to threaten or to kill or to want to kill the other party. So they can lose this protection if, for example, they participate in hostility in one way or another, despite the fact that they are wounded or sick. And so this is quite important to also have in mind. Now, what we have seen indeed is that there has been an increased, or at least there is a discussion of attacks on hospitals and medical units such as ambulances. The law of armed conflict also requires these units and ambulances to be protected from attack under indeed the law of armed conflict. And this is quite clear, is that they have to be fully protected from attack and from being ill-treated. There is, similarly to the protection of the wounded and sick persons, there is a similar protection, similar rather limitation of this obligation, which is if a medical unit like an ambulance or a hospital is used for military purposes, then they lose their protection. So I will give you an example. If an ambulance is, and it has been the case in the past, we have seen, for example, that members of non-state armed groups, so for example, the Islamic State in Syria, was regularly using ambulances to carry weapons, or were hiding, using, in fact, this possibility that ambulances could not be attacked to use them as some kind of a perfidy. And so once it is shown that indeed these medical units are used for military purposes, they lose their protection and they can be attacked. There is a particular extra obligation for hospitals. Hospitals also are absolutely protected unless they may host, for example, or be used with some actions that might be harmful to the enemy. Again, here, the same example, if some members of the armed forces of a state or a non-state armed group either hide in a hospital, use a military wing of the hospital, and these are examples, these occur a lot, where actually some fighting are indeed being done either in the really vicinity of the hospital, under the hospital, in some of the part of the hospitals, then the hospital loses its protection and can be attacked, can be targeted by the enemy force. But there is this extra obligation which requires from the party to the armed conflict to actually warn the hospital of the attack. Why it needs to warn it? Because indeed the hospital need to be able to evacuate the wounded and sick that are living in the hospital. So this is an obligation which is often forgotten. When the hospital in Kunduz, Afghanistan was attacked by US forces, there were indeed allegations that the Taliban were hiding in part of this hospital, but there was also a big discussion as to effective warning was indeed given or not. And in fact, some of the conclusion of some inquiries shown that effective warning from this attack was not given at that time. So as I said, there is these obligations are applicable to both the state actors and the non-state actors. And this is an important thing to keep in mind, because the majority of the conflicts today are indeed of involving non-state actors as well. And by non-state actors, I mean members of or armed groups per se. And an extra, another obligation which is important in this context to highlight is the access to healthcare, the possibility for the medical personnel and also medical supplies to reach either the hospitals or the places where there are wounded and sick persons. And so this is a clear rule under the law of armed conflict, is that access to healthcare infrastructure shall not be arbitrarily denied or limited. And this is a clear obligation that is pending both on state and non-state actors. So if we summarize a little bit the rights and responsibilities. So you have this obligation of care, which means that all the possible measures have to be taken in order to provide for healthcare. There is an obligation to collect, so to collect and evacuate all the wounded and sick within a particular zone. There is an obligation to protect the persons and the object, not so that they are not attacked. You have also parties to the armed conflict need to protect against any interference in providing for healthcare. There is, and I haven't gone into the detail, but there is a whole set of obligations about the emblems, not to use or to misuse the emblems that protect, in fact, these medical units, that access to healthcare cannot be denied or limited. And of course, you also need to ensure that healthcare personnel are in a position to ensure that they can perform their work in all the standards of ethical practice. And here there are some examples during, especially of what we call counterterrorism measures, and there are some examples of pressure exercised by some administration, in particular under U.S. counterterrorism legislation, where there was pressure exercised on doctors not to necessarily provide, or to at least ensure that some wounded ISIS fighters were either immediately arrested, or they were perhaps not under exactly the same kind of protection that would have been required by IHL. And this is also, there are also many examples by armed groups that there is this pressure done on doctors, for example, to first heal and treat their own soldiers rather than governmental forces. And so there are indeed examples of that kind in armed conflict situation. I don't want to take too much time, but I would like to finish with at least some highlight under human rights law, because we have talked about indeed the law of armed conflict, but of course, human rights law indeed applies also in armed conflict situation, and there is a right which is protected under the law of human rights, which is the right to health. And in general, it acts as a complementarity with the law of armed conflict in most situations. The only limitation that we might find under human rights law is that there is a big debate that human rights law apply to armed non-state actors, whereas the law of armed conflict applies the same way to armed non-state actors and state actors. Now, some reflection on the, let's say, the policy side, or the how did the international community try to address this? Because as we have seen, and as was discussed also by the former speaker, is that there are indeed a quite robust set of norms, but the problem is one of implementation. And so studies such as the one that was mentioned on Chatham House, but also by Chatham House, and also other studies that have been done by the ICRC that documents the attacks on medical personnel on hospitals are very, very useful. And there has been some, let's say, reflection whether or not in the past years there was an actual increase in the attacks on medical personnel or not. And here MSF, Doctors Without Borders, have done a very interesting study which has demonstrated that in fact attacks on medical personnel, but also on doctors, young doctors, even medical students, are quite common practices by members of the armed forces, either states or non-state actors, in order to demoralize the enemy, which is of course completely contrary to international humanitarian law and even to human rights law. And so what the problem lies with when it is indeed becoming a strategy by a member of the armed forces of one party to the armed conflict. And here, the accent should be put on the fact that attacking medical personnel, medical unit, or the more than 6 civilians or soldiers are war crimes, can be constituted as war crimes. So there is a possibility to ensure individual criminal responsibility for these acts. And here we've seen that there has been, at least in the latest denomination of some arrest warrants done by the ICC, which have not been confirmed yet, but on the case of Israel and Gaza, where indeed the hindrance and the attack on medical personnel were mentioned as possible war crimes or even crimes against humanity, and this is a good thing. We have also to mention the UNSC resolution that was adopted in 2016, which reiterated the obligation of state parties and non-state parties to respect medical personnel and medical infrastructure. And really last word, because my predecessor speaker has talked about this in times of pandemics and such as COVID. There was an interesting example, which is slightly different from what I just mentioned. But when we have a problem under the law of armed conflict and as well as human rights law, when you have an armed non-state actor that controls a territory for a certain period of time. And so because there is this difficulty of ensuring that armed non-state actors have obligations under human rights law, there has been issues of ensuring that armed non-state actors have access to some of the vaccines that normally are only delivered to state actors. And so there was a big question, in particular when it came to the Kurdish armed groups in northern Syria, to what extent could they have a direct access to some vaccines in order to ensure that the population that they were controlling in northeast Syria could have access to COVID vaccines. And this is a problem of policy which is not resolved yet, and which has to be part of any kind of health diplomacy that we are mentioning. I hope I have not been too long, but there's so much to say that, and I try to be as clear as possible. But if there is any question, I'm of course completely available for the Q&A. Thank you.
Thank you very much. No, the subject is so interesting. There's so many things that we have to talk, and I'm pretty sure during the Q&A sessions and the closing remarks, we're going to be expanding on that. Thank you, Dr. Belal, for bringing the overview of international humanitarian law and how it's relevant to health during war, and including the protections of medical personnel, health facility, and also the integration of how international frames health as a human right during conflicts. Going a little bit more into how health diplomacy versus humanitarian health, the linkage and the overlap, and how we unlock this blockage. I am happy to introduce our next speaker, which is Asef Tarakan, who is the co-director of the Humanitarian Mediation Program at the Center of the Humanitarian Dialogue. Since 2000, he's been in the center since 2007, and he's managing projects across South and Southeast Asia, and he's developing humanitarian initiatives in the East and the West Africa since 2015. Following his previous work, he worked in trade negotiation and institutional reform, the South Center, and UNTAC and WTO, and he holds degrees of Stephen College from Delhi and the University of Essex. So without further ado, I pass the floor to Asef Tarakan.
Thank you, Catherine. I work for the Center for Humanitarian Dialogue, which is essentially a peacemaking and conflict resolution organization. So broadly, what I would be speaking about is the synergies between the worlds of peacemaking and health. And I speak to it based on over a decade of engagement which HT has had with global health actors in working to facilitate access to hard-to-reach areas which are mostly in conflict zones. And basically, we see this as an area where there is scope for a lot more engagement between these two communities. And maybe just to dive into it, I think the first point I would make is from the perspective of the health community, how the peacemaking community can help. That is where often the health and the humanitarian community are often blocked in terms of access negotiations because they are often dealing also because of the mandate of humanitarian organizations. You're often limited to engaging with actors who have those sort of files on the side of the armed groups and armed actors, whereas often to unblock these areas, you often also need to engage with people in those systems who are dealing more with the political or the military or the security side of it. And I think that's where the peacemaking community can often help the health community, because by the nature of the work on which peacemaking organizations work on, they often have those contacts, and they often have topics on the agenda which people holding, so on the military, security, political side, topics which they're interested in engaging on. So again, a synergy where you can take a package of things to actors is of interest to the health community, which is trying to unblock and has to engage these actors, which is way beyond the usual humanitarian or health norm. And I think a second point where there is synergy is often that I think the peace process actors can help the health community with community health trust building, because again, by virtue of the essence of the peacemaking work, it is about having excellent networks with the community at various levels of leadership. So it's a useful network to amplify messages for the health community. Now, from the perspective of the peacemaking community, why this synergy is useful is, I would say, it boils down to a couple of points. The first is that it's often the entry points are very important for peace processes. What's the point in which, particularly when actors are in active conflict, there are very few points often in which to start a discussion, and health is often a topic which which both parties sometimes can find as a point to engage on. And so that is of great interest to the peacemaking community as an issue which can be, which is often very helpful in opening up lines of contact. The second point is that often peace processes are very long processes, taking many, many years. And often there are huge gaps in those processes. I mean, when there is, on the political front, there is little scope because for movement. And in those periods of lull, again, to keep the discussion and lines open, again, it's very helpful to have an issue like health or health access negotiations, which often all parties see as valuable to keep going, despite some sort of political solution often not being there. Then from a very operational perspective, again, when we have topics like this from the peacemaking community, it's useful because it allows us a chance to engage with both sides, understand how the structures of both sides work. It's health is often a great confidence building measure, which is both a confidence building both in terms of the process of the peace talks, but also to ensure that everyone who's engaging together, that they get used to engaging to each other, how to coordinate, how to unclose blockages, all of which then translates into when you're talking about other more political issues. Maybe what I'll just my last point maybe is that, and as alluded to earlier by previous speakers too, is that for example in 2023, ICRC estimates that there are about 195 million people living in areas under fluid or complete control of non-state armed groups. So in essence, non-state spaces, and often these are areas where there's obviously conflict. Conflict is very much a part of these areas often. And then you have big global health challenges like pandemic preparedness, or epidemic diseases, which really cross all borders, cross conflicts, and there's interest in everyone to work together. And then you have large parts of the world in which a lot of the global discussions on these issues like pandemic preparedness, etc., it's difficult to engage with people who control those areas. And I think that is, again, an area of work where the worlds of peacemaking and the worlds of the global health community and the humanitarian world, there is scope for greater synergy, because those are areas where you will need new forms of engagement, because the formal structures we have don't always fit neatly into these very sensitive areas. So maybe with that, I will leave it for now and happy for any questions. Thank you.
Thank you. Thank you very much for the inputs and to be able to highlight the importance of mediations within this kind of these conflicts. I would like to remind that we have the Q&A, so please continue posting your questions. And if you have directed questions to any of the speakers, please identify it there. Thank you also for the insight. We're going to discuss a little bit more on how health diplomacy comes into place when there is mediation between non-actor states. To go now to analyze how health diplomacy is in support of the health workers in war and humanitarian contexts, I have the pleasure to introduce Dr. Duhas Shelat, who is currently in the West Bank. She's a junior Palestinian physician and scientific and medical journalist. She serves right now as a co-chair of the WHO Youth Council for the Eastern Mediterranean region. She's a research lead at the Young Council of the World Federation of Public Health Association and is a chapter chair of the Women in Global Health in Palestine. She has been recognized as an outstanding young physician in 2022 and is one of the 41 emerging voices of global health in 2024. She's also the founder and the chairwoman of the research organization, and she's promoted youth engagement in scientific research. So she demonstrates the importance of having youth in health diplomacy. So with further ado, I pass the floor to Dr. Shelat.
Thank you so much for the introduction. So I may be able to share my screen. Thank you again for inviting me to speak at this important webinar at this critical time for me personally as a Palestinian and for all people who are living under conflict and in fragile contexts and for the globe we are living in. So I will be talking more about health diplomacy and support of healthcare workers in war and the humanitarian context. So to start with, what is health diplomacy? It's a collaborative approach to address global health challenges involving negotiation and partnership among various stakeholders. And why we say that by health advocacy, by health diplomacy, it's important to support healthcare workers in conflict zone, as healthcare workers are the first responders in crisis, and their support is vital actually for effective health outcomes in war and humanitarian situations. And the ongoing conflicts where I live right now in Palestine, Lebanon, in the whole region, and other areas in the world, these ongoing conflicts globally highlight the need for strategic health diplomacy, and we need to think together for a more strong voice for health diplomacy. So actually, the role of healthcare workers in a humanitarian context, first of all, because they are the first responders in delivering critical medical care in these emergencies, and they have also the community trust. Also, they help in building trust within communities and facilitating better health communication and care. And they do face challenges. First of all, of course, safety risks, and they themselves been attacked, and we have seen this in where I live and where I work in Palestine. We have seen this in Gaza. They have been attacked themselves. They have been under violence. And also they are dealing with resource limitation, the scarcity of medical supplies and medicine and facilities, and the destruction of the infrastructure and facilities. And of course, the psychological and emotional toll they are, and the pressure they are working under, especially they are dealing in the same, and they are facing the same displacement and challenges that all people are facing right now. So when we talk about health diplomacy, actually the goal is to enhance global health equity and to prevent disease outbreaks and to support health system strengthening in these vulnerable regions. And when we talk about the stakeholders we need to work on when we are speaking about health diplomacy and its use for the support of health workers, we are talking about governments, NGOs like MSF, and of course international organizations such as WHO and the local communities. And of course, we'll be tapping more upon specific examples, talking more about Palestine and Lebanon. And my colleagues who spoke earlier elaborated more about the situation in Syria and also in Yemen, where collaborative efforts regarding health diplomacy to provide medical aid despite ongoing conflict were really helpful. So actually, we foresee the outcome from health diplomacy in such critical times is to improve access to medical care, negotiation of safe passage for aid, and increase international awareness for health crisis. So we need to know that the support mechanisms for healthcare workers in such critical times during emergencies would be the psychological support by programs for trauma counseling, peer support networks, and training for self-care and coping mechanisms, and the training and resources workshops, emergency response, mental health care, absolutely, access to necessary medical supplies and technology by telemedicine and mobile clinics. And we need to see that collaborative efforts are really needed at such time when we talk about more collaborative work through the international organizations, public-private partnerships also, when we see that it would leverage resources and expertise such as technology companies providing telehealth services in remote areas. So what would be the policy recommendations? First of all, the advocacy for health diplomacy is to encourage countries to prioritize health diplomacy. And I would say that it's now like never before we see that how much is important to build our systems for a much stronger health diplomacy, and also to focus on young physicians and young professionals in the field who would be the future health diplomats, and also foster partnerships between health and foreign affairs sectors, and support the frameworks, develop national policies which focused on the protection of healthcare workers, and implement the training programs in conflict setting sensitive healthcare delivery to be prepared pre-emergency or in suspected emergency areas. So in conclusion, the health diplomacy is essential for addressing health needs, and it's essential to support healthcare workers, not only improves individual well-being, but also enhances overall health outcomes in affected regions. So my first call to action would be is to encourage all stakeholders to invest in health diplomacy and support systems for healthcare workers. So what would be the most significant barriers to implement effective health diplomacy when we want to support healthcare workers in conflict settings? First of all, the geopolitical tensions from conflicts and instability. This is trust between nations also, and limited resources, funding constraints, healthcare infrastructure, and bureaucratic challenges like inside the systems, complex regulatory environments, or slow decision-making processes, and also the culture itself and the cultural differences when we talk about language barriers and diverse health beliefs also. Lack of political will, and we have seen this. We are seeing this clearly in the current war, when we can see that the lack of political will is hindering access to healthcare and the support of the healthcare system in Palestine and Lebanon. So prioritizing issues, health may not be prioritized in foreign policy agendas, leading to insufficient commitment, and also changing political landscapes, which although this shift in leadership or policy direction would also disrupt ongoing health diplomacy efforts, and inadequate stakeholder engagement, either limited participation of the local actors or fragmented approaches. And of course, one of the challenges would be public perception and misinformation, and the technological barriers, as we see technology as a tool needed than ever before. So addressing these barriers, to overcome these barriers, it's essential to foster dialogue and trust among stakeholders, secure sustainable funding, enhance local engagement, and prioritize health in diplomatic agendas. So building also strong partnerships between governments, NGOs, and local communities can also facilitate more effective health diplomacy. So when we talk more about the conflicts and their effects on health systems and the global impact, over 1.3 billion people live in fragile and conflict-affected areas, according to the World Bank, and 80% of the world humanitarian needs are in conflict-affected countries, according to the UN OCHA. So the impact on health system, as my previous colleagues stated very clearly, disruption of healthcare services, increased disease outbreaks, like we have seen in cholera in Yemen, and rising mortality rates. So I would be moving to talk more about specifically the Palestinian. Okay, so the Palestinian situation and the healthcare challenges in Palestine. So the ongoing war, it's been over a year right now, and of course we can deny the siege. If we are talking specifically about Gaza, the 17-year siege on Gaza, which been hindering the access of access to medical supplies and medications to Gaza Strip, and also the occupation and the movement restrictions and the checkpoints and settler violence inside the West Bank, which has been really hindering the access of people to healthcare facilities. Making our health system overstretched and under-resourced. So the ongoing war has significantly impacted health systems in the West Bank and Gaza Strip, from blockages to restrictions and military actions contribute to a humanitarian crisis. So over 2 million people in Gaza face severe restrictions on movement, affecting access to healthcare right now because of the total destruction of the infrastructure, specifically talking about the healthcare, and over 60% of the medical supplies needed to be imported, unfortunately, are underfunded. Also, we are talking more about specifically that we have in Gaza Strip, we have high prevalence of chronic diseases, which been denied because also of the destruction of the healthcare system. We are talking more about 20-30% of adults have diabetes and 16% have hypertension. And we also talk about maternal and child health indicators are really concerning now, with a maternal mortality ratio around 75 deaths per 100,000 live births. So the impact of the ongoing conflict and the siege and the military actions in the Palestinian territories. So we would say that approximately 50% of the healthcare facilities in Gaza are non-functional right now. And I'm sure that most of us are aware and following up the news and the reports that have been produced by WHO, OPT, and WHO, EMRO, and UN OCHA and other concerns, international NGOs who are working tirelessly, covering what is happening actually specifically to the healthcare system in Palestine, and of course the shortage in wash services and also the electricity cuts that would also affect the medical services and they provide to people. And would also think about in such dire time about mental health, that the ongoing conflict contributes to high rates of PTSD and depression among the population. And we can't forget also that this is not the first war for Gaza. And beside the siege that's been happening since 17 years, also we are talking about military escalation since 2008. And we can say how much is it's a huge burden to people, not only healthcare workers, but people, trauma after trauma, and violence after violence they are dealing with. So what would be the international response? First of all, according specifying humanitarian aid, various NGOs, including MSF, Red Cross, provide medical services and supplies. And also we have seen UNRWA, which plays a critical role in delivering health services to Palestinian refugees since it's been established in the West Bank, in Gaza, not only in Gaza, in the West Bank, in other Palestinian refugee camps, also in neighboring countries. And now we can see how, unfortunately, UNRWA being attacked. So the challenges also for aid delivery, restrictions on the import of medical supplies and equipment due to blockages, aid often insufficient to meet also the overwhelming needs for the Gazan populations. And of course, we all are aware of the role of the healthcare workers. As we said, they are the first responders in such time. But unfortunately, despite all the the advocacy work and the international organizations work to raise the alarm on their the necessity of their protection and not being them as dealing with healthcare workers, healthcare facilities as a target. We have seen and of course WHO has been reporting the attacks on healthcare facilities since this work started in Gaza and in the West Bank also. Even though in the West Bank, healthcare facilities are being targeted by raids and also ambulances being targeted, and they are blocked on checkpoints, hindering their work and hindering them to reach out to people who are injured or even to take people to hospitals because of the huge number of military checkpoints all around the West Bank. So the health diplomacy efforts would be international advocacy, of course, calls for increased diplomatic efforts to ensure access to healthcare for the Palestinians and to protect healthcare workers in conflict zones, and collaboration opportunities, encouraging partnerships between, of course, the authorities and Palestinian authorities and the International Health Organization to strengthen the healthcare system. So the healthcare crisis in Palestine requires urgent attention and a comprehensive approach to address the multifaceted challenges, and strengthening health diplomacy and support for healthcare workers is essential for improving the situation on the ground. And of course, now the situation is extending to Lebanon. And of course, Lebanon has its own also challenges before. They've been facing challenges before the current escalation and the current military escalation, from healthcare financing and the economic crisis that have been happening in Lebanon. And of course, talking about the brain drain that healthcare professionals are facing right now due to poor working conditions and low salaries. So it would be the same message also for the attacks that we are following up now and recording and reporting happening also in Lebanon, that we need to increase diplomatic efforts, and we need to see that health diplomacy is important and it should be in our agendas, and also not for now, also for the future, and also to try as much as possible to invest currently and also in the younger generation that they will be lead more in the future. So the recommendations, and would be my final takeaway messages. So what would be the recommendations for strengthening health diplomacy in conflict zones, mainly to protect healthcare workers, enhance multilateral collaboration by strengthening partnerships and joint initiatives, prioritize humanitarian access, ceasefire, negotiate ceasefires for aid and legal frameworks, of course, to promote adherence to international humanitarian law, to protect healthcare workers and facilities, and to engage the local communities, involve local healthcare workers and community leaders to implement and to plan health initiatives to ensure cultural relevance, training and capacity building, even under these dire situations, focus on mental health support, psychological services, and resilience training, and utilize technology if possible, of course, even though with the cut of electricity and much restrictions also would leave us with a question how we can use technology, even though if doctors or nurses can't communicate together even via phone or SMS. And of course, we need to advocate for funding and resources, sustainable financing and innovative funding models, explore public-private partnerships and crowdfunding possibilities, of course. And we need also to strengthen health systems, infrastructure development, invest in rebuilding and strengthen health infrastructure. And the health system, if we need to think also about the rebuilding of the health system in Gaza and the public health system, and we need to bring all experts to think about how we can vision this rebuilding of the system, and which it should be starting now, and it may take even till 10 years. And so on. And essential services, also we need to focus on delivering essential health services, including immunization, maternal care, and chronic disease management, even in unstable environment. And we have seen this, like when we speak about polio immunization and the work that have been done between WHO and the collaboration with Palestinian Ministry of health in Gaza and the campaign for polio immunization, monitoring and evaluation, of course, and promote advocacy and awareness. Public campaigns highlight success stories to be shared and share successful health diplomacy initiatives to inspire further collaboration and investment, especially during this time. People have lost belief in that diplomacy could have the solutions, and actually we need to share successful examples of that. Health diplomacy has worked, and we need to work more for a successful health diplomacy model. And of course, we need to address gender and vulnerable populations when we talk about what we can do for health diplomacy and to success and to protect healthcare workers, and of course to work with inclusive approaches. And my final message, of course, my first and final message would be ceasefire now. Thank you so much.
Thank you for your presentation and just for bringing your inputs and recommendation as well as to bring in the current situation in Gaza and Palestine, and also to bring the importance of health diplomacy and keeping the hope that health diplomacy, to look at the positive side of how health diplomacy can support in those conflict zones. Just finally, we will dive into how health response and coordination in conflict zone strengthen global emergency system. And for that, I'm going to invite Elena Volo, who is the country office deputy representative of the World Health Organization in Myanmar. Elena Volo has joined UN as a junior professional office in 2008 and has served in several agencies from UNDP, UNICEF, WHO, mostly in fragile settings. She has also worked as a fellow researcher in the Inter-American Development Bank on health and WASH initiatives. So with further ado, I'll pass the floor to Elena Volo.
Good evening, everybody, and I hope that internet will stay stable so that I can be with you until the end of the webinar. Good evening, good afternoon, good morning to everybody who is connected to this webinar. I don't want to repeat most of the concept and key issues that the other colleagues have already been sharing with everybody on this webinar. But what I would like very much to talk about is the importance of global health diplomacy in protracted emergencies, particularly when we are dealing with de facto authorities, with rebel groups. So let's start from a fundamental question. You are in Congo DRC. You are in the, unfortunately, extremely forgotten Central African Republic. How do you keep your counterparts in the field accountable? And how do you keep your counterparts taking care of the health of the people, of everybody, when the concept of everybody is not the same idea, when that everybody is different from the rebels, from the de facto authorities with which you are dealing every day, because that everybody has a different religious belief, was born in a different area of the country, or simply belongs to a different ethnic group. Here, it's where the global health diplomacy in the field, in protracted emergencies and non-protracted emergencies, is quite critical. Without entering into semantics or models and the theoretical part of global health diplomacy, and before we share a few examples and before we talk about why it's relevant in the field, why it's relevant in neglected, forgotten emergencies, I just would like to also to elaborate a little bit about the importance of global health diplomacy in the field vis-a-vis the core diplomacy and the multi-stakeholder diplomacy. Different schools of thinking about global health diplomacy say that the core diplomacy is the negotiation among nations, right? It's what takes us to the pandemic treaty, for example. Then you have the multi-stakeholder diplomacy. It's the diplomacy between nations and other stakeholders, civil society, and non-state actors, according to the definition of WHO. But then you have the so-called informal health diplomacy, which in theory is what happens on the ground. Now, I would like very much to remark that the global health diplomacy that we do in the field is in reality a mix, it's a combination. There is an element of formality and there is an element of informality. The element of formality builds on the existing structures that we have at the interagency UN level, through the cluster system, the intercluster system, through the establishment of the humanitarian country team, whereby we have UN, but also we have international NGOs, national NGOs, humanitarian donor groups, and other voices, other stakeholders representing also other constituencies at the local level. And then there is the informal global health diplomacy, which builds on the interactions with partners on the ground at the very subnational level, at the grassroots level, not only at the capitals of the countries where you are sitting, but there is also the element of informal negotiation, engagement, discussion around global health, which happens also with the actors who have nothing to do with global health. And this could be military constituencies. These could be actors coming from other sectors that you will think have nothing to do with the program that you're trying to keep, sustain, running on the ground, but indeed have a lot to say. Now, why do we need global health in the field? If we have treaties, if we have international humanitarian law, if we have principles that have been established since the last 1 century, as we heard before by some of the participants to this webinar, why do we still need the people with the skills and capacity to move forward the global health diplomacy, to implement global health diplomacy on the ground? The answer is simple. You heard it already from the other participants. Health is under attack. And the more a crisis, humanitarian crisis, is forgotten, the more a country is isolated geographically, politically, geopolitically, the more certain constituencies will take advantage to take away from people their right to health and to protection along to the right to health. But health is under attack for different reasons. It's not just the bombing against an hospital. It's not just unfortunately, the continuous and increasing attacks that we see against healthcare workers, midwives, not only medical doctors, all cadres, all typologies of healthcare workers. Health is under attack also, particularly in protracted, neglected, forgotten emergencies, when other constituencies are taking advantage of this vacuum, of this emptiness that comes from the lack of attention of the international community, and are using the countries where the protracted emergencies are happening, for example, for illicit drug trafficking, for shifting factories to produce drugs, for human trafficking, but also to exploit, for example, the local pharmaceutical market, bringing medicines which are of low quality. And I'm very glad, Catherine, that at the beginning of this webinar, you raised the point about not only antimicrobial resistance, but also the use of antibiotics and the use of substandard and not quality medicines that more often, more and more we see are reaching countries where citizens, where the civil society have no right to decide on the quality and type of medicines they have access to, if they can get access. But health is under attack also when, let's say, you have military interests that are either arising from within the country where we are working or from neighboring countries, whereby basically diseases are becoming a weapon. It's easy to have people dying from malaria, so let's make sure that the communities in certain locations don't get malaria treatment, for example. And health is also under attack because, as we have seen also from the war in Ukraine, for example, more and more we have informal groups of power that are influencing certain countries and are taking the governance and are replacing actually the governance role of certain regime, of certain authorities, diverting and steering the political agenda towards a certain direction, directions that have nothing to do with global health or national health needs, directions that refer more to international geopolitical interest. And this is why, for example, you have Afghanistan, Syria right now, which have become some of the largest producers of synthetic drugs, for example. And this is the reason why you have untold stories of human trafficking coming from Venezuela, another forgotten, neglected crisis. If we shift our focus from this side of the world, where I'm talking to you, from South and Central America. So when we see the complexity of health being under attack, not only physical attack, but also diplomatic attack, which creates also some consequences that maybe are not visible in the immediate term, but indeed are visible in the mid and long term, global health diplomacy becomes the only way through formal and informal modalities of engagement to reduce the impact of the status quo. Typical examples of global health diplomacy, and some of the colleagues have already mentioned them, are all collectively, health actors on the ground, facilitating the dialogue in order to roll out campaigns, vaccination campaigns. Polio has always been the traditional example, right? From the peace days that we used to broker in Afghanistan with the Taliban, to the polio vaccination campaigns that my colleagues and other organizations have managed and succeeded to have in Gaza, for example. But the global health is also necessary when in protracted and neglected emergencies, the health system has collapsed, there is barely a surveillance capacity in place, and suddenly you have an emerging threat, you have an outbreak. And the more the country has a system which has collapsed, the higher is the perception or non-perception, the factual reality of the risk that you're running if you don't take an immediate response. And if your constituencies do not have even a seat at World Health Assembly, because simply they are not even recognized as a government at the UN Security Council, that's when you are activating your global health diplomacy. That's where you're activating all possible channels in order to set up a response. But also global health diplomacy is critical to reduce the burden that populations have gone through years and years of conflict and negligence. One of the participants to this webinar was referring to the importance of global health diplomacy in post-conflict situations. Unfortunately, there are several countries whereby people aged 20, 25-year-old were born in a conflict and they continue living in an active conflict. Central African Republic is one of the best examples. Now, what happens when you were born in a country that is in active conflict for the last 25 years? You have higher exposure to negative coping mechanism. You have very likely zero expenditure from the regime controlling your country, from the military rebels groups, for example, controlling the areas where you're living, zero investment, certainly in public health. That's the list of the priorities. And that's when then the global health diplomacy apparatus enters into the game in order to make sure that by facilitating access to medicines, by facilitating access to healthcare workers, we reduce the burden that these communities, these populations are going through. But another critical element very close to my heart coming from WHO, and I believe for everybody who's on this webinar, it's the fact that we need global health diplomacy into action, because also global health is under attack in terms of misinformation, miscommunication. Very often we see that the science, the public health evidence is manipulated, and it's manipulated and it's used as part of political, geopolitical, military games that constituencies are like very much to play on the ground, either within a country or across the borders of that country. And then there is another element. To global health diplomacy, it's critical to make sure that a country-based crisis does not become a regional crisis. And very often we should also learn from mistakes, right? It's important. Very often we have been considering in the past Afghanistan, Yemen as a single country crisis. There is no spillover, there are no consequences for the neighboring countries. But let's see right now what's happening in the case of Yemen, where what was believed to be a crisis, a political crisis, has become one of the worst and irreversible for many aspects, humanitarian crisis in the Middle East. And I'm not here to compare the pain of people. I cannot say the emergency A is more relevant than the emergency B. And that's also very important. And we go back to the importance of global health diplomacy. Global health diplomacy is also critical to contextualize the needs, to contextualize the impact that we are generating in not taking action. Regardless of the region, crisis should not be compared. And this is one of the most difficult jobs that colleagues being directly involved in global health diplomacy have to carry out every day. There is no comparison among crises. The suffering is equal, and the risk that a midwife runs in DRC, in Central African Republic, is the same risk that a midwife is running currently in Syria or in Yemen, or even in the country where I'm talking to you, where I'm sitting right now. But on the other side, I think that also is very much important to recognize the importance also, beside the formal, the cluster system, the humanitarian country team, to recognize the importance of the informal engagement related to global health diplomacy on the ground. Because very often we tend also to forget that each person delivering health services, delivering from medicines for diabetes treatment to safe delivery for a pregnant woman, is a person that in certain settings is an advocate for global health diplomacy. And this, I think, it's very much critical because we have a formal and informal system of global health diplomacy on the ground. Now, those who are working more on the formal system are also have the duty to make sure also that a neglected emergency is not forgotten, and that donors also keep the commitment to maintain a minimum presence, a minimum support. Those who work more in the formal apparatus of global health diplomacy also have to make sure that they engage also with non-global health actors, especially when non-global health actors are taking decisions that are going to have a direct impact on the health of communities. Very practical example, July 2024, the US government decided to stop food aid in Yemen. I don't have to explain the consequences for a country where the health system is fully collapsed and a country which features one of the worst indicators in terms of severe acute malnourished children. So many times the role of global health diplomats is also to talk to non-global health experts. And then the importance of the global health diplomats who are delivering services, who are reaching out to communities through informal platforms is equally to be recognized. Not only recognized in terms of the work that they do, but particularly in terms of the richness of the cross-cultural information that they bring to facilitate and to maintain the dialogue and to better understand how the local context changes over time. Because also what happens very often in a neglected, forgotten crisis, we have sudden changes of who is the power holder, but this information doesn't really go up to the capitals. I would just like to close, because I know also that we need to leave space for questions, with a very final remark. And the very final remark is the element of protection. Very often we are told if you want to advocate for the sustainment of your health programs to support health partners on the ground, you need to generate evidence. But I would just like to remark that not always the evidence generation is possible. And this is the reason why also the creation of safe environment, safe space for maintaining and promoting global health diplomacy within and outside the countries where we are working remains quite critical. And I stop here so that we can leave the floor to participants for questions. Thank you.
Thank you very much, Elena. This has been a really insightful information, and you have covered some of the questions that have been posed in the chat and the Q&A. So now we pass to the Q&A. We are running out of time, but I think some of the questions that have already been already covered. I will jump in to mention a few of the questions, and then from there I will ask for all the speakers also to either answer the questions and also have final remarks. So one of the questions is, how do international sanctions affect healthcare in the current situation in Russia and in Ukraine? And how can the warnings still be considered effectively delivered in terms of safety and evacuate safety of the premises? Another question is related to how, considering conflict crisis, how profoundly affect by ethical, religious, and political significance, and how can we support health workers in conflict areas to uphold humanitarian principles, and if these principles are still applicable. So I think these summarize some of the questions, some of the others that had been answered. So briefly, if all speakers can give final remarks trying to answer that, we have less than 1 minute for each of you, much less than that. Thank you. I think I will start with Dr. Bella, if that's okay.
No, so perhaps I will just try to answer one of the questions with regard to the warning that I saw on the chat. It is indeed one of the issues that we see in contemporary conflicts, how to warn and to ensure that civilians are evacuated safely. This is also an obligation under IHL. So indeed, of course, the parties to the armed conflict, not only do they have the obligation not to attack civilians or medical units and personnel, but they also have the duty and the obligation to ensure that civilians, including the wounded and sick, are evacuated safely. So all of these if they are violated of these norms, they can provoke the possibility to have individual criminal responsibility. And one perhaps last thing, there was also a comment on the chat that how can we do? I think from my side as a lawyer, one of the ways that we can ensure better implementation is to ensure that there is no impunity. And this is a big problem today, is that we see that responsibles of alleged war crimes, including attacks on hospitals and medical personnel, are not tried by international criminal courts or even by domestic courts. And I think this is something which is a clear weakness from the international contemporary system. And so it would be my plea to ensure that these violations are indeed accounted for. So that would be my last remark.
Thank you. Really brief, Dr. Kesayed.
Yeah, I think the question related maybe to attacks on healthcare generally in terms of protection. I think we need to advocate for different policies and guidelines related to humanitarian interventions in complex settings. So one of the issues, for example, that we're advocating for example, that humanitarian donors should accept that, in the design of health facilities, there should be maybe elements sometimes for even fortifications, which in other settings might not be considered, or changing the layout of facilities to consider these attacks. Also, improving guidelines for evacuations, especially when it comes to medical evacuations for people under siege. And I think a final word is really we need to think about health diplomacy not only as related to access, also let's think about how this can be used as a bridge of peace, and also building health systems that can adapt, recover, and thrive in the most challenging environments.
Thank you. Also, Tarakan.
Thank you. I think I'll just reinforce 2 points which were made by previous participants, particularly Elena, that I think health diplomacy needs to talk to other non-health parts of diplomacy, and there are synergies which can be created. So I think I just reinforce and leave at that point.
Thank you. Dr. Shella?
Thank you. So I want to emphasize on what have been said, especially by Dr. Abdul Karim and Dr. Bilal. And of course, health diplomacy is needed much now, like never before. And let's focus also on the young generation, the young professionals, especially I represent them in the Youth Council, and we need to work more on the health diplomacy. And also my final plea is ceasefire, and we need ceasefire right now in the Middle East. Thank you.
Thank you very much, Elena.
Yeah, it's very difficult to have final remarks after this discussion, particularly after listening to Dr. Dua in West Bank. My very final remark is being humble, meaning very often we go to certain countries where we have crisis with, sorry to say so, I'm Italian, with Western models. And I think that one of the best lessons on how the Western approach fails, if we don't really understand the formal and informal mechanisms of rule of law governance that are in those countries where we are working, is Afghanistan. So my last remark is very much to stay humble and to understand really the context where we are operating. We have the tools, we have the international humanitarian law principles, but it's up to us, the technical and moral obligation, to make them work in the specific context and situation where we are working. Comparing the diplomatic approach of Gaza cannot stand comparing Gaza with Afghanistan 10 years, for example. So we need to learn also from the past and stay humble. Thank you.
The speaker, this has been a really interesting webinar, and I think it is not going to be the last one, and we're happy that you have joined. Please follow up on the events and the work that the Health Diplomacy Alliance is going to be having on this area. We thank our speakers. We thank the Geneva Graduate Institute, the Global Health Center, as a co-host of this event. And I also want to express my thanks to all the staff of the Health Diplomacy Alliance. Please keep updated on our latest news, and thank you for joining us.